Wakama, one of the critical care nurses in the main ICU. Today, we are going to take you through the drug and fluid management in the critically ill patient. We are going to have Mary Juma as our presenter. Mary Juma is one of our critical nurses who has worked with us for more than 10 years in the unit. She's a Bachelor of Degree holder in nursing with a master's degree in critical care specialization. She leads in the youth and mentorship, and she's also one of our customer care champion, a eloquent speaker. I know you are going to enjoy. We shall be open for questions at the end of this, and welcome you all. Thank you for joining him, and we appreciate your support as you join him. Thank you so much.
Thank you so much. Good afternoon, everyone. Today, we are going to talk about drug and fluid management in the critically ill patients. And because we are going to touch on fluid resuscitation, we found it wise that we introduce a little bit of resuscitation. So the objectives will be drug management, fluid therapy, common fluids used, and fluid resuscitation. And we are going to talk about resuscitation care so that as you do fluid resuscitation, you are not in the dark on what to do after the fluid resuscitation. So resuscitation is the act of bringing someone or something back to life. Cardiopulmonary resuscitation involves a series of life-saving actions that improve chances of survival after cardiac arrest. Effective resuscitation requires an integrated response known as the systems of care, and that is according to SLS Manual 2015. The systems of care may include the staff, the environment, the equipment, and all that. So Peterson et al. Talked about cardiopulmonary resuscitation being the cornerstone in the treatment of cardiac arrest and is directly linked to survival rates. He goes ahead and says that nurses are first responders and need to be skilled and competent in CPR to ensure favorable patient outcomes. Nurses being the first responders and witnesses of in-hospital cardiac arrest, the survival rates are disappointing due to inadequate trainings, which hinder in most of the time them from acting, and they have to wait for advanced cardiac team to come and help. That is according to Peterson et al. 2017. Improving survival rates by implementing strategies that reduce errors and optimize resuscitation performance is therefore key and very important. That is according to Hunt et al. 2018. Hunt et al. Developed resuscitation quality bundle associated with improved compliance with American Heart Association guidelines, with key components being active surveillance of cardiac arrest events, structured cardiac arrest debriefing programs to enable objective data evaluation, and more so to capture the lessons of the debriefing program. These programs involves looking at cardiac arrest that's occurred, and as you look at it, you review the objective data, like you want to see how was the patient pre-arrest, and was there anything that could have been done to prevent the arrest. Cardiac arrest is the cessation of circulation, whereby the heart stops pumping and the heart's electrical system stops working. Chances of survival and return to functional recovery and length of stay of stop-stall will depend on the cause of cardiac arrest and duration taken before management is initiated. Like I said, in-hospital cardiac arrest is commonly preceded by physiological changes, with nearly 80% of patients having had abnormal vitals. So that's why we need to be extra vigilant as nurses, as healthcare workers, because if these patients, most of them had abnormal vitals, then there's something that we would have done to prevent the arrest. CPR remains cornerstone in the treatment and linked to survival rates. And nurses being first responders, they need to be skilled and competent And that skill and competency. Competency means gaining the skill, knowledge and skills and retaining them. Because now things of cardiovascular system and even medicine at large, guidelines change. So as nurses are trained, if you are trained in 2010, you need to get updates so that you keep at par with the current knowledge. Critically ill patients, now we go to drug management. Critically ill patients are a population at high risk for more frequent and more severe medication-related events. Critically ill patients receive twice the number of medications than non-critically ill hospitalized patients. Thus, this puts them at higher risk of adverse drug events. The critically ill patients are more likely to have drug-to-drug interactions, drug accumulation due to failing organs. Remember, they have critical illness and comorbidities might be there, and sensitivity to drug responses resulting from their labile status. The complexity of the patient's drug regimens and the environment provide a risk for patient harm. Remember, this is a critical ill patient, maybe a polytrauma patient whose hemodynamics have to be stabilized and has also a lot of drugs. So the environment, you have a lot of pumps, you have a lot of medications to give. So this might provide a risk for patient harm. So that calls for extra vigilance, extra monitoring. As we continue, there are drug administration gaps that might occur, not because you intend for them to occur, but because of the environment you are working at and the intensity of the management you are doing. So there can be inappropriate drug planning on the treatment plan charts with omissions on drugs already prescribed in the treatment sheet. So in the event that now you don't plan appropriately for the medications, then you might omit a drug, and that now, as you omit a drug, that is now a drug medication error. So there are misses on planning of drug frequencies or inconsistencies on the same. For example, you might find the treatment sheet is written paracetamol 1 gram IV TDS. And then when you go to plan, you change the frequency. You may write paracetamol 1 gram IV QID. So remember, for example, some of these drugs we give to the patients, remember this is a patient with critical illness. If you give paracetamol QID and was not prescribed QID, the doctor, maybe the prescribing physician, had a reason why he or she prescribed TDS. Remember, drugs are chemicals, and paracetamol, for example, is very toxic to the liver. So you might be exposing these patients to other morbidities that they didn't have. And as we continue, just the previous slide, yeah. Lack of documentation resulting to misses or overdose of the drug. You have given a drug, you have given medication, but you have not documented. Remember, in health systems, we say anything not documented is not done. So when I come, I enter my shift and find that at 6, this patient was to get paracetamol. Yes, you've given paracetamol according to you, but you have not checked against the paracetamol. For me, that is a drug that you've not given. So I will give, and that will lead to overdose. As we go on, inadequate knowledge on modes of drug reconstitutions. Yes, patient is supposed to get hypertonic saline, but you don't have the knowledge on how to dilute the hypertonic saline. So you end up giving maybe a more concentrated dose than was required. So this is a drug medication, a drug error, so might be harmful to the patient. Wrong timings of drug administration. We all know that a TDS drug should be given 3 times a day. So that means in a day we have 24 hours. So that means that this drug should be given 8 hours apart. But now you give it at 8 in the morning, or maybe at 10, and then at 4, you are giving the drug. 8 hours have not elapsed. So this is wrong timings of drug administration. And this is a drug error. This will can lead to toxicity of the drug. So it's important that as we give medications, we be vigilant, we keep on monitoring, and we stick to the prescription. Wrong drug administration due to incomplete knowledge of the drug in terms of drug names, dosages, routes, and how to reconstitute, or at what flows the drug should be administered. For example, in a critical care setup, you are giving noradrenaline via pump. The dosage prescribed is 0.5 mics per kg. Then the way you prepare the drug, there is no clear indication of what was your concentration, or you don't know, you are not sure of how to calculate the dosage so that you know the meals that you are supposed to run per minute or per hour. So that will bring a drug error. Drug administration errors occurring as a result of look-alike, sound-alike drugs. It's important that when you have look-alike drugs, you really ensure that they are well labeled, because maybe you wanted to give adrenaline, it looks like atropine. Do the two drugs act the same? Definitely not. So that may bring confusion, and the results might not be good to the patients. Improper drug storage in terms of room temperatures, the refrigerated and non-refrigerated drugs. For example, we have insulin. You've withdrawn the insulin. There are some insulin that you're supposed to keep in the fridge, but some, after commencing use, you are supposed to keep under room temperature. So it's important that we learn to know how to keep our drugs so that we don't lose potency, to ensure that the efficacy is maintained. The gaps continues. There's misses on patient identification, resulting to patients being administered the wrong drug. Yes, I want to give an example of the critical care setup, because that is where I am coming from. Most of the patients are on antithrombotic prophylaxis, that is Clexane. So there is a patient that you are supposed to give Clexane, but those who have been in critical care area, you know, you are in a bracket whereby you might be having 2 patients. So you don't correctly identify the patient, so you end up giving Clexane to the wrong patient. Of course, you didn't intend, but it's an error that can occur, and it's a gap. So it's very important, because in most of our institutions, we are passionate about patient safety, because if that happens, then the patient safety is at risk. Because if maybe I was from surgery with intraventricular hemorrhage and you give me Clexane, you can imagine what will happen. So it's very important. As we move on, wrong routes or methods of drug administration due to lack of accessible sites for drug administration, hence reduced drug efficacy. Yeah, that is also key to note, so that you don't give drugs using the wrong route, because if I was to get IV and you give me oral, then the absorption issues comes in and the efficacy might be tampered with. Wrong timings of drugs not being given at the specific times of administration, because maybe you want to change shifts, so you are giving the drugs at 5 instead of 6. So it's important that that is also looked at. Then administration of unprescribed drugs, especially antidepressants, opioids. You feel that, of course, a critically ill patient might not verbalize pain at times, So to you as a nurse, as a healthcare provider, you might feel that this patient is on pain, so you decide to give morphine. But it depends with the setup that you are in, because at times if you give morphine on a little bit higher dose, it might depress the respiratory center. So it's important that you only administer the prescribed drugs. Rights of drug administration, we have right routes. We talked about that. These are most of the things that we talked about. So patient identification is key, and documentation is key. Labeling of drugs is also key. For example, a case scenario. Nurse A comes to the shift and is working with Nurse B. Nurse A puts normal saline and adds phenytoin in the saline. But because the saline is not labeled to have phenytoin in it, so the Nurse B comes with potassium chloride. The potassium is low and you want to supplement. Then you are like, there's saline here, I can use this saline. So you add the potassium to the phenytoin. That will be detrimental and will be harmful. So it's important that labeling of drugs, especially for the critically ill patients who is in having many medications, many drugs, the labeling is very, very important. Because we are going to touch on resuscitation, as we do fluid resuscitation, we found it wise to tackle a little bit of the drugs that we commonly use. A drug like adrenaline, I've talked about noradrenaline, but now adrenaline, which we normally use so much during resuscitation. It's important that the nurse or the physician knows about the mode of actions of these drugs, the side effects, and what to expect, the outcome. We know adrenaline is good to the heart, but might be detrimental to the brain. Adrenaline produces vasoconstriction, which increases blood pressure and heart rate, and improves perfusion pressure to the heart. But as you give adrenaline, it's important, next slide. It's important that you monitor the patient during and even after resuscitation, because adrenaline during resuscitation is given 1 milligram every 3 to 5 minutes as you continue with the chest compressions until you receive you achieve spontaneous return of spontaneous circulation. So patient monitoring is key during, after resuscitation to avoid again the very bad side effects of these drugs. In that line, you should continue monitoring blood pressure. Since adrenaline and heart rates, and better still, if you have cardiac monitoring, that is okay, because adrenaline might cause arrhythmias, which might also lead you to another cardiac arrest. So it's important to monitor the patient. The blood glucose level also is very important to monitor in a patient during cardiac arrest and even post, as a post-resuscitation care. Atropine is also given. Remember, drug use in resuscitation is tailored towards the cause and the presentation. So if you had a bradycardia, you are likely to use atropine. So it's important that you also monitor the patient after and even during the resuscitation as you use these drugs. Like I said, most of the drugs that were commonly used in resuscitation nowadays, evidence shows that drugs like sodium bicarbonate should only be used or given with the evidence of a lab result indicating acidosis. And also a drug like calcium gluconate should only be used when you have evidence of hypocalcemia, because we know as hypocalcemia is bad to the heart, hyper is also bad to the heart. So it's important that you use them with evidence that you really need to use them, not as a routine during resuscitation. Well, we are now going to fluid therapy. I know somebody might ask, a webinar like this, international, that involves all hospitals, all healthcare workers. Why should we talk about fluids? Somebody might feel that fluid is just something that you hang there and you go your way, but no. Remember the role fluid plays in the physiology. The 60-40-20 rule, whereby 60% of body weight is water, of which 40% is in the intracellular compartment, while 20% is in the extracellular compartment. So that is very important because we now again know that 42 liters of, we have 42 liters of fluid, and the intracellular has around 28 liters, and our extracellular around 14. So with that knowledge, you'll really appreciate the role that fluids play in our body system. The significance of fluids, like I said, fluid is very important. It helps in homeostasis. Body cells survive in the fluid medium, what we call the internal environment. And fluid also provides a transport medium where nutrients, gases, and all other molecules are transported. Fluid also helps in metabolic reactions, gives texture of tissues, and also in temperature regulation. So that is a good background to let us know that fluid is very important, and that's why you can get a cardiac arrest from hypovolemia. Remember the H's and G's. Hypovolemia is one of the commonest reversible causes of cardiac arrest. So that makes you know that fluid is very important, and fluid management as well. Intravenous fluid therapy is one of the most common interventions in critically ill patients. Fluid administration is a pharmacological prescription with three main indications, that is resuscitation, replacement, and maintenance. The common types of fluids we use, we have the crystalloids and the colloids. Crystalloids contain electrolytes and non-electrolyte solids and can move freely around the body's fluid compartment. It's divided into isotonic, hypertonic, and hypotonic based on their ability to shift water across the semi-permeable membrane. Isotonic fluid is maintains equilibrium. That means it has the same osmolality as body fluids. That means that when this fluid is put in red blood cells and plasma, then water cannot shift either from the cell or outside the cell. So that's how it maintains equilibrium. And examples of those fluids, we have the normal saline, the 0.9%, and we have the lactated ringers. These fluids given for perfusion support and volume replacement, and that's their role and how we use them for fluid resuscitation. We have hypertonic. Hypertonic fluids has a greater effective osmolality than the body's fluids and cause fluids to exit the cell. For example, 2% sodium chloride, when you give these solutions, then fluid is likely to exit the cell. And that is how they are used, the hypertonic saline used in maybe brain edema, because it will enable fluid to shift outside the cell and reduce the swelling. We have hypotonic fluids. These fluids have less effective osmolality than the body fluids and make water move into the cells. So if this happens, then there will be swelling. So examples of these fluids is 0.45% sodium chloride and 5% dextrose in water. We have colloids. Colloids consist of larger molecules and restricted to plasma compartments. These types of fluids are used in patients who do not respond to crystalloids. Of course, you won't want to to just begin from colloids. If you can, if your hypovolemia can be corrected by normal saline or venous lactate, which is cheap, why should you go to dextran or the starches, the Hemacel? It's important that you only use them when you really need them. The colloids can be natural or synthetic. Still evidence-based, crystalloids have small molecules. They are cheap, easy to use, and provide immediate fluid resuscitation. But these fluids may increase the pulmonary and tissue edema, while on the other hand, colloids have larger molecules, cost more, and may provide swifter volume expansion in the intravascular space, but may cause allergies, kidney failure, especially in patients with sepsis. And that is according to Sister et al. 2018. Fluid resuscitation as we continue. And because we are talking of critically ill patients, these patients may lose fluid due to serious conditions, infections, e.g. sepsis, trauma, burns, and most of them may have post-surgeries with surgical site losses, like patients with abdominal surgeries. A patient may be having a Bogota bag. The insensible losses might be increased. So these patients require fluid replacement urgently to prevent dehydration. And of course, we know when you are dehydrated, your kidneys will be interfered with. So you can also go to kidney failure. So we dehydrate our patients to prevent some of these things. Because for example, a bottle of Ringer's lactate might not cost as much as a hemodialysis session. So as healthcare providers, it's important that we avoid the avoidables. You try to manage the patient so that you try to avoid the complications. Because if you don't give fluid, this patient goes to kidney failure, then you start patient on hemodialysis, which is very expensive and increased cost of healthcare to the patient for no good reason. Fluid resuscitation is the act of infusing a significant volume of fluid with the goal of maintaining homeostasis, that is improving tissue perfusion and cardiac output. Some of the indicators that a patient requires fluid resuscitation include hypotension. Of course, a patient may be dehydrated and you see the blood pressures going down. You start a patient on norepinephrine, which is expensive, whereas fluid therapy would have helped this patient to help maintain the normal blood pressure. So it's very important to take seriously fluid therapy. When a patient maybe has hypotension, increased heart rate, capillary refill above 2 seconds, and increased respiratory rates, these are some of the indicators that a patient may require fluid replacement. Conditions where fluid resuscitation is recommended or required. We have trauma with acute blood loss. A patient has come, is a polytrauma patient with fractures of the long bones, pelvic fracture. Patient has lost a considerable amount of blood and fluid. Then this is a patient that requires fluid resuscitation to ensure that the physiology is not tampered with. So you can give 1 to 2 liters bolus or 20 mils per kg. But this is given as you monitor. You don't just give fluid because you should give, but you monitor the patient clinically. Maybe a patient has come to you, quite a number of volume has been infused, which is not documented. So it's important that we don't just function as robots, but you look at the patient clinically and really determine whether fluid resuscitation is required. In sepsis, Patients will require fluid resuscitation in sepsis, and the fluid that is recommended is 30 mL per kg within the first 3 hours. And in hemorrhagic shock, you also might need fluid resuscitation. In burns, a patient requires fluids, and normally in burns, we use the Parkland's formula, which says that you give 4 mL per kg multiplied by the total body burn surface area. And this half of it to given in 8 hours, then remaining in 16 hours. Fluid resuscitation is a fundamental intervention in the management of critically ill patients. However, just like I said, a careful assessment of safety, efficacy, and cost effectiveness of various fluids used in resuscitation is important. So, because if you don't look at that, then you might also overload the patient. So the key element in fluid resuscitation is the adequacy of the volume that you infuse, the timing, because if you want to pump me with fluids, once I'm already in kidney failure, then you will be doing more harm than good to me as a patient. So the timing is also very important, and monitoring of the results to prevent fluid overload. Monitor, monitor, monitor the patient as you give fluids so that you don't cause more harm to the patient. The aim of fluid resuscitation is to reverse tissue hypoperfusion. Hence, time is critical, like I said, do it in good time. For example, in septic shock, the Surviving Sepsis Campaign guidelines recommend 30 mL, just like in the other slide, per kg within 3 hours, with continuous assessment of fluid responsiveness. And that's according to Barker et al. 2021. As we move from resuscitation, yes, you've resuscitated your patient with fluid, and now your patient is out of danger. Then if this patient is not able to take orally or not able to take enough fluids, then you need fluid maintenance. And in children, the dosages that are normally given for maintenance, like the Holiday Heger formula that says that 0 to 10 kg, you give 4 mL per kg. Then from 10 to 20 kg, you give 2 mL per kg per hour. Sorry, there is no per hour there. There should be per hour. Then any kg above 20, you give 1 mL per kg per hour. And adult dosages varies from 30 to 35 mL per kg per day. So it's important that even after resuscitation, you keep on checking whether your patient is getting enough. So if not, then you do a maintenance fluid as maintenance therapy. Like I said, a nurse is an advocate. A nurse is always the person who is with the patient throughout. So as a nurse, because this is nursing series, you are supposed to monitor. As you monitor for hypovolemia, then you must also be aware of the potential complications and their symptoms. The complications that comes with infusing large volumes of fluids may include hypothermia. For example, a patient has come, patient has burns, and you are infusing cold normosaline or cold Ringer's lactate to this patient. You have infused maybe 2 liters to this patient, cold. Remember, in burns, the skin integrity that also regulates blood temperature is not intact. So there's a tendency to lose heat. Then again, you infuse cold fluid. So this patient may also have hypothermia as a complication. So you have to be very vigilant and play your role so that you don't get these complications. Fluid therapy, you can also get acid-base disturbances. Depending on the fluids you are using, you can get hyperkalemia, hypocalcemia, clotting problems, and allergic reactions. So monitoring is very, very important. And then as you monitor, for any reactions, you also monitor the temperature, the blood pressure, so that your vitals are within the normal limits. Fluid administration must not be given without full knowledge of immediate and delayed effects. You know, many might think that fluids yata mama yangu anaweza weka, or anybody can just hang the fluids. You have to have the knowledge of the immediate and delayed effects, the toxicity and implications for nursing care, as it requires thought and exercise of professional judgment. So also monitor the lactate levels, because mostly when you're doing resuscitation, then the lactate levels continue to be high. This might tell you that there is reduction in tissue perfusion. So those are some of the parameters that we should look at. Nursing observation continues. It is very important to maintain fluid intake and output chart. This is something that we really can do and stick to help us. Before you go to invasive monitoring, you can just do this simple one within your reach. Very easy to do, doesn't cost you a lot of time. Maintain the fluid intake and output charts, so that, yes, you are doing fluid resuscitation, but you find that these patients, you have infused 3 liters of fluid, and the urine output is 100 mils. I think that calls for an alarm, and if your chart is well maintained, then that will help you detect any problem. Remember, one of the principles of critical care is early identification of problems. So if you maintain this chart faithfully, so to say, then you will be able to capture a problem like a patient going into AKI, acute kidney injury, early, and measures taken so that this patient interventions are initiated to correct the kidney injury. Another parameter you can use, the central venous pressure. It is also important to monitor the central venous pressure, but this can only apply when you have the central venous lines. So research and studies are all around, and some say that it doesn't hold water per se, but still in most institutions it's used. Central venous pressure is pressure created by the volume in the right side of the heart. And this can be used as a guide to avoid fluid overload, or to see where you are as far as the fluids is concerned. So it's very important for patients, especially those receiving fluid resuscitation. And because we touched on resuscitation, and even as you do fluid resuscitation, you have to know that these patients, like I said earlier, I have given fluids, but the care after fluid resuscitation, remember, we talked of the complications. So as you do that, then you should know a little bit of what to do post-resuscitation. And that's why these slides come in. And according to Nolan et al. 2021, post-resuscitation care begins immediately after return of spontaneous circulation is achieved. And the care involves the diagnosis and treatment of the cause of cardiac arrest. Remember, we talked about cardiac arrest. Some of the reversible causes, we had to touch on this because we were talking of hypovolemia, because we do fluid therapy in hypovolemia. So hypovolemia is a common reversible cause of cardiac arrest. Some of the causes, we have the H, they're called the H and T's. We have hypovolemia, we have hypoxia, we have hydrogen ions imbalance, that's acidosis. We also have hypokalemia, hyperkalemia, and the T's, which we have tension pneumothorax. We also have cardiac tamponade, they're not there. But I'm touching on this because you are to get the diagnosis of what caused the cardiac arrest as you do post-resuscitation care. So if you get the diagnosis or the cause of the arrest, then the management is tailored towards reversing the cause. Effective ventilation is very key in post-resuscitation care, and management of circulation, to try as much as possible to avoid hypotension, restore normal fluid volume. That's why we talked about fluid therapy. And at this juncture, you might want to use the vasopressors, for example, the noradrenaline, to help you maintain normal pressures. As post-resuscitation continues, you are supposed to do total temperature management to prevent hypothermia and fever, at least for 72 hours after resuscitation. Remember, post-resuscitation care is very important because some researchers say that most patients you might achieve return of spontaneous circulation, but the patient might die 24 hours later. So the post-resuscitation care is very important for a critically ill patient. As you do that, you should also maintain normal glucose level by regular glucose monitoring. That is something that is achievable. And patients post-resuscitation are prone to having convulsions or seizures. So it's important that you diagnose them in good time. And I will do this one. So you should ensure adequate urine outputs. Urine outputs recommended is 0.5 to 10 to 1 to 0.1. So above 0.5 ml per kg should be the adequate urine output that you are supposed to get. So I can see several participants raising hands. You'll be given time in a minute to answer the question, to ask any question that you have. So it's very important that you diagnose and treat convulsions or seizures using the recommended and the correct anti-convulsants, so that the patient, remember, convulsion might be detrimental and the patient might end up with brain injury. So it's important to manage that as a post-resuscitation care. Continue. Because now a critically ill patient, in most cases, will not tell you I'm in pain. This patient will not tell you that my condition has changed, or might not tell you that I'm fine now. So it's important that as you take care of the critically ill patients. You also take care of the significant others, the family. If you are resuscitating a patient or a patient's condition has just changed, it's important that after the resuscitation, you tell the family or the significant others that the condition changed and we did this and this and this, so that at least they know the events that happened or they are appraised, so that you don't just tell the patient that, we are sorry we lost your patient. Because remember, in critical illness and critical care, there is also limitations of critical care. So you might resuscitate and resuscitate, and then you see that you are not going to achieve maybe return of spontaneous circulation. There are parameters that tells you that you are losing the fight. So it's important that you let the family know as a post-resuscitation care that yes, patient A went into respiratory arrest or cardiac arrest. We did this in the simplest terms possible. Because I remember a scenario whereby a relative, you tell a relative that the patient might have brainstem death. Then they are like, sister, ni brain imekufa, mwili yote bado iko hai. So it's important that as you explain, use the simplest term that the relatives can really comprehend. So it's very important, even as we care for the patients. In drugs, we have the drug alert labels. So as you do medication, that's something that I forgot, very key. You should put the alert labels. Like you are infusing potassium chloride, you should ensure that you have the red alert, so that you don't infuse it like you are doing plain lactated ringers, because it might also be very detrimental to the patients. And because we don't just do continuous education for the sake. So because we don't just do continuous education for the sake, as we do continuous nursing series, then this series should change us, should change our attitude, should change the way we do things. And what we really want to achieve by this is to improve quality of the care that we offer to our patients. Whether you are in the county hospital, whether you are in a non-governmental organization, whether you're in Kenyatta, Nairobi Hospital, all we want as healthcare providers is to achieve quality and get good outcomes for our patients. So, a few recommendations. As we do fluid therapy, drug therapy, as we do resuscitation, there are a few things that need to be enhanced, like all healthcare institutions, to ensure that healthcare professionals get continuous trainings on some of these things, like continuous education on BLS, ACLS, even though you don't go for the ones that gives you certificates, but these small sessions can really help us improve our knowledge. Remember, researchers are done daily, and we should be appraised with the current knowledge. So maybe you did ACLS in 2012, maybe something has changed. It's important that we keep ourselves updated. In a hospital setup, in wherever you are dealing with the patients, especially critically ill patients, supply chain management system is very key, because this will ensure timely availability of essential medicines and supplies. For example, maybe you are in a health center, a patient has just come, a road traffic accident has just occurred in your locality, and then a patient is brought to your center, patients who has bled a lot, and maybe you lack ringers, you lack fluids, you cannot even give fluids. So your hands are tied. You might have the knowledge, but do you have the supply so that it helps you to save this life? So supply management is very important in all our setups. And as far as resuscitation is concerned, remember we talked about the debriefing. Debriefing should be more like a reflective session, whereby maybe Nurse J was nursing a patient who went into cardiac arrest. CPR was initiated. And then, regardless of the outcome, as a team, we should come up and say and find out what happened. Like we said, most of the arrests can be prevented because we were told that the physiology or patients had abnormal vitals before. So we want to review the objective data of this patient. This patient arrested at 3 p.m. But how was this patient at 2:30 p.m.? Were the parameters acceptable? Was this patient hemodynamically stable? And if not, what was the temperature? What was the blood pressure? Was there something that we missed? And these sessions should be free of witch hunt, free of victimization, so that they help us to bridge the gaps. So they be informative, such that we learn that, yes, this patient, when we did a blood gas during resuscitation, the pH was 7.0. So this patient, the RS might have been caused by acidosis. So we learn from there that the next time we check patients' parameters before, so that we can prevent the RS that really can cause us the lives of our patients. So it's important also that the sessions we are doing, it's good that we are having these sessions all over. We are doing the gynecological sessions, the cancer. So as it's important that we always log in, and that information should add to our existing knowledge and to apply the knowledge to our clinical areas so that we improve the care that we give to our patients. So as we move towards the end, we will give questions, people to ask questions, to add on whatever we say. But we say thank you for that, giving us the opportunity to talk about fluid and drug. Questions.
So we are starting the Q&A, and meanwhile we shall be answering the questions. So in case one of you has any question, you can still continue to type it on. We are ready for you. Thank you. So we have Judy Kimei. You are asking about volume expanders like Imacell or Voluven. How much can one give before getting blood?
Okay, thank you, Judy, for that question. It's very nice that it has come up. The volume expanders like Hemacell and Voluben, remember when you have a patient who has lost blood, the Voluben and Hemacell will not act like blood. They are just the volume expanders. They expand your intravascular volume. So it's important that they are just given as a resuscitative measure as you look for blood and transfuse the patient. Because if the problem is blood loss, then the patient will benefit more from getting blood. I hope I've answered you.
Is it okay, Judy? Next question, we have kindly comment on fluid management in a patient with acute kidney injury or a CCF, congestive cardiac failure.
Thank you, Pauline Kamau. Fluid management and maintenance of fluid input and output chart, very key for a patient with acute kidney injury and a patient with congestive cardiac failure. Because you remember, a patient with kidney injury, the kidneys are not working properly. Hence, this patient is not in a position to probably get to have adequate urine output. So as fluid management is very key for this group of patients, because if my kidneys cannot really work well and you are infusing a lot of fluid to me, you will increase the edema. This fluid that you are infusing will not be able to help the patient per se, and this is a patient that you should really organize for, so that hemodialysis can be done to correct the discrepancies. And also in congestive cardiac failure, you should give fluid with caution, because now this is a heart that is weakened, and if you pump more fluids, then this patient will present with, you will increase the cardiac muscles fatigue. So it's important that fluids are given with caution as you strictly monitor. Strict monitor, use the fluid input and output chart, use the central venous pressure monitoring, and use the parameters like the blood pressure. Let them guide so that you don't pump in excess fluids, because excess fluid also is detrimental. Remember, excess fluid can cause pulmonary edema. Excess fluid can cause a lot of issues to the patient. So it's good fluids are given with caution as you monitor strictly. The catch there is strict monitoring, and you only give what is really required.
So as we continue, Pauline, you are asking, does 50% have any purpose in fluid resuscitation or in any hydration at all?
50% per se, we don't use the 50% in resuscitation. 50% is glucose, and mostly 50% we use in when you are correcting maybe the hypoglycemia. Remember, when you give patient 50%, then you are likely to increase the blood glucose level. So it's not a good fluid that can be used for hydration per se.
So how does normal saline, is normal saline helpful in one who has a low HB as far as 6?
Thank you so much, Kiprotich. Normal saline is a crystalloid. A patient who has a HB of 6 requires blood. You need to increase that blood level, because the moment you have HB of 6, even your oxygen carrying capacity is hampered. So the best treatment for this patient is to transfuse patient blood. Normal saline will not help per se.
How about fluid management in eclampsia? Any protocol for that? Monica is asking.
Okay. In eclampsia, protocol of fluid management will depend on, is this patient, remember when we talked about fluid replacement, fluid resuscitation, and fluid maintenance. If we are talking of eclampsia, what do we plan to achieve when we give fluids? Because you have to do, either you are resuscitating, you are doing fluid resuscitation, or you are giving maintenance for a patient who is not able to take orally or take enough fluids, that is maintenance. And you are replacing the insensible and sensible losses. So if the patient with eclampsia do not fall under these categories, maybe the patient do not require replacement, do not require resuscitation, and do not require maintenance, then you might not really want to pump this patient with fluids, because remember, this patient might have edema and all the likes, unless there's a medication, maybe you are giving magnesium sulfate using the fluids.
So Patrick, you're asking. No, Mary, you're asking, how many doses of adrenaline can you give to a critical ill patient before stopping resuscitation?
Thank you so much, Mary. Remember, when we are doing resuscitation, the guideline that we use is the American Heart Association guidelines. And the guidelines tells us that you give adrenaline 3 to 5 minutes apart, 1 milligram, 3 to 5 minutes apart. But stopping resuscitation will depend with the treating physician and the resuscitation team, because there are parameters. For a patient who is maybe in ICU, you have a capnograph and you are monitoring the end tidal CO2. Then these are some of the parameters that when you have CO2 of less than 10 or 10 and below, this tells you that something is not going well, and maybe you are not going to achieve much. So the number of adrenalines to give is not really documented, but stopping resuscitation will depend with the team and the clinical presentation of the patient. And in most cases, you even look at how was the patient before resuscitation. Maybe this patient had maybe brainstem death, patient had very bad vitals, and you have done resuscitation for like an hour or so, and nothing seems to be working. You are not achieving return of spontaneous circulation. Then the team decides that, yes, colleagues, we have done this for this time, and we've given adrenalines like this. We have given this, and we are not achieving return of spontaneous circulation. So it's the team to decide, unless the patient maybe. Another thing to stop resuscitation is when maybe there was a do not resuscitate orders, so that makes you stop. But if they weren't, then you really decide among the treating physician and the team and the clinical presentation of the patient at the moment, so that you don't resuscitate like forever also, and you're achieving nothing.
Thank you, Patrick. Your question is not off. You are asking us, how do you calculate fluids in a sickle cell crisis?
Okay. In sickle cell crisis, remember, in sickle cell crisis, we are dealing with a patient who the red blood cells are being hemolyzed at a very high rate. And I don't have adequate updates on when blood is given and when blood is not given, because it's an area that I've not dealt with for a time. But what I know, pain management is key, but fluid therapy will depend on the clinical presentation of the patient, because you want to manage pain and you want to ensure that the blood volume or the HB is within the required parameters. Thank you, but that is something that we will do further research on.
So, Mary, you are asking, how often should one do the BLS, SELS course?
Mary, thank you. If you are intending to retain your certification, then certificates expires after 2 years. But these BLS, SELS courses, remember, competency is about gaining knowledge and skills and retaining. We tend to forget, and even in psychology, they say what you don't use, it extinguishes. So it's important that you can just always do small courses for BLS, SELS, or you just refresh yourself. But if you want to retain the certification, then the certificate expires after 2 years. Thank you.
Thank you, Martina. You are asking, how often do we check random blood sugars in our nil pahoro patients in the ICU?
Okay, thank you, Martina. One of the, in ICU, we have a mnemonic that says fast hug. The G in the mnemonic is glycemic control. So the blood sugar monitoring, not only for the nil oral patients, but blood sugar monitoring is key for ICU patients, because you remember, if you are not eating, then you are likely to go into hypoglycemia. Maybe you are taking medications like dexamethasone, you are likely to go into hyperglycemia. So the hypo and hyper are frequent in critically ill patients, and blood sugar monitoring is important. And it's important that if a patient is not feeding, then a 2-hourly blood sugar monitoring is important. Thank you.
Causes cardiac arrest. What antibiotics should we start on? One thing you need to know, Bashir, is that sepsis-associated cardiac arrest is a relatively common occurrence with especially poor outcomes. But generally, we don't have a specific antibiotic we can say that is what we are going to treat the cardiac arrest as a result of the sepsis. But you find most of our patients in the critical care, prophylactically, they could be on an antibiotic, and if not, there has to be a reason to why. So we have no specific on what kind of an antibiotic to give to patients to arrest sepsis secondary to, which can lead to a cardiac arrest.
Next is we have now Gershon Abakalwa. You are asking, please kindly comment on parental nutrition products for critically ill patients. And then you have appreciated our presentation. Thank you so much, Gershon. Stella.
Yes, Gershon, parenteral nutrition, as most of us know, is an intravenous infusion. And it accounts to almost 50% of our patients who are probably not doing the parenteral feeds. So like you had how much it's a multidisciplinary. We got our nutritionists with us who give us the precision to go around with it. But one major thing you need to know in the critical care is that this parenteral nutrition, you need to know, are we meeting the daily requirements of the nutritional feeds? Again, you need to monitor the random blood sugars, because most of these nutritional parenteral nutrition rise the blood sugars of the patients. So we weigh both. We work together with the nutritionists, hand in hand. They are giving us the target on how much we need to give to the patients. We are there monitoring the random blood sugars to see whether we are right. And we are also assessing our patients on the weights and whether we are really doing good on the nutritional value of that patient. Thank you.
Jidungu, you are asking, kindly elaborate why dextrose fluids are not administered to patients with head trauma.
Okay, thank you so much, Jane. Dextrose fluids, for example, I don't know the concentration you are talking about, but like we said, in head trauma, the patient is likely to develop edema. And when you develop edema, then you want a fluid that maintains equilibrium, or this fluid that will help you not to increase the intracranial pressures in the brain. So that's why we use fluids that are the isotonic fluids, because we said when you put isotonic fluids in red blood cells or plasma, they maintain the equilibrium. The water does not leave the cell or get inside the cell, because in head injury, we don't want these patients, we don't want water inside the cell of the brain, inside the brain cells. So it's important that you give the isotonic, which will maintain the equilibrium. And that's why we don't administer the dextrose, because they will either shift the water inside the cell and increase the edema in the brain.
You have not written your name, but please, you're asking, we clarify on hypertonic saline in cerebral edema, and you also have appreciated our presentation. Thank you so much. But because of time, Mary will be very fast on answering that one, because she already put it up in the next.
Okay, thank you so much. I said hypertonic saline is, we remember we had classification under crystalloids. We have the isotonic, the hypertonic, and the hypotonic. We said hypertonic, they have greater effective osmolality with the red blood cells and the plasma. So when you have cerebral edema, you want fluid to shift from the cells outside. So that's why you are giving a fluid with greater osmolality to help relieve the edema by shifting the extra fluid out of the cell.
Dominic Okello, you have asked us, can you use Ringer's lactate in place of normal saline in case you don't have the latter? Stella is answering that one.
Yes, Dominic, you can. Ringer's lactate, you can use it in case you don't have normal saline. Remember what Hauma told us, these are all crystalloids. And you find that they almost play the same role. It's only that the contents might be different. Like you find, we mostly use Ringer's lactate because we say it's a physiologic fluid. You find that it will really like equilibrate the hemostasis of the body fluid. So in case you don't have normal saline, you can use Ringer's lactate.
Next is Bernard Otieno. How do you go about patients whose religious backgrounds do not allow blood transfusion?
Thank you so much, Bernard. I love the question because I know people from a certain denomination, I won't say which, but they normally work with cards written, do not resuscitate me, do not transfuse me. So this is their religious background. If you have a patient, remember when you are caring for the patient, respect for the patient, and the patient is an autonomous person. If this patient has a Glasgow Coma scale of 15 and he has told me, you do not give me blood, then you are tied. Your hands are tied. But the thing is, you can document that this patient required blood according to the assessment deed, but declined blood. So the patient might sign against that because it's their denomination and it's their belief that blood is bad for them. Thank you.
Bonyo is just saying we'll do more research on blood transfusion practices in critical ill patients. Our department will organize again maybe for that presentation. But next is, she didn't tell their name, shed some light on the type of fluid recommended for head injury patients.
I think we have said that.
Yeah, that one we have already answered. Someone else is asking, which fluid can be used in severe asphyxia?
Okay, thank you so much. Severe asphyxia might be a gray area for us, but fluid therapy, just make sure that as you give fluid, you work towards achieving the three purposes of fluid, either maintenance, replacement, or resuscitation. Thank you.
Moses is asking next, how will you do fluid management in patients with hypertension and diabetic patient with hyperglycemia with a glucometer reading which is high above 35 millimoles per liter?
Thank you, Moses, for that question. Remember, these are two diagnoses. We have hypertension and we have diabetes. When I start with hypertension, remember we are talking about the pump, the cardiovascular. So most of these patients probably will present with edema, meaning they have a lot of extravascular fluid than the intracellular. So you need to avoid fluids which will bring out fluid from the blood vessels to the extravascular. So, and for the hyperglycemia, you need to give fluids which will be less with glucose levels so that you may be able to intervene on such situations.
And we are really rushing because of time, please. Justus is asking, is there fluid restrictions during resuscitation for renal failure patients? And if yes, how should it be administered? Stella is answering that.
Thank you, Justus. Renal failure patients, meaning the kidney is failing. So we are not able to excrete fluid as it is required. So we need to minimize fluids on these patients. We don't need to overload them because the kidney cannot do what it's supposed to do. So these patients, we need to really monitor the fluids, the rate at which we are giving the fluids. We don't overvolume them because if we do, we shall be causing a more harm than the good.
The next question is, when do we stop the fluid and what are the risks of ongoing fluid administration? Mary will just go through it very fast.
Okay, like we've said, you don't just give fluids because you are giving fluids. The fluid therapy should be guided with your judgment as a physician or as a nurse and the condition of the patients, like in different conditions. So you give fluid and you monitor the inputs and output charts. And there are what we call fluid response. As this is the patient, I'm giving fluids. Maybe what patients need is not fluid now, it's blood. So it's important that you don't just continue giving fluids. You are guided by the parameters of the patient and by the parameters and the condition of the patient.
We have the last two questions. Getich Nicholas is asking, clarify how Hartmann's fluid is related with internal edema.
Okay, we said Hartmann's is under isotonic, and we said that high isotonic fluids maintain equilibrium, but these fluids, when given in large volume, can cause edema. So it's upon the provider to assess the patient and see whether fluid therapy is really required for that patient.
The last question is, both saline and ringers are out of stock. I think you want to mean when you don't have those ones in your facility, what do we do? Stella will finalize with it.
Remember, we said these two fluids are crystalloids. So you need to go and you need to check on what other crystalloid you have in the unit and probably use it. And sometimes some books say you can do distilled water for the same, but caution has to be there because there's a way you need to reconstitute them to reach at a normal saline and a ringer's concentrate.
And that's why we said that supply chain management is key so that you don't miss the essential things. And patient's physical assessment is key in all that we do. Thank you. Everyone for attending the session. We really appreciate. And our wish is that these sessions will help us improve the quality of the patients that we come across. Thank you, thank you, thank you.